Hi everyone, welcome back to my YouTube channel. In today's video, I will be talking about CMS proposed rule for hospital inpatient and long-term care hospitals prospective payment system for fiscal year 2023. Let's dive right in. On April 18th of 2022, the Centers for Medicare and Medicaid Services or CMS issued the fiscal year 2023 Medicare Hospital Inpatient Prospective Payment System or IPPS and Long-Term Care Hospital or LTCH Prospective Payment System or PPS proposed rule. The subsequent slides contain some of the takeaways from the proposed rule. Background on the Inpatient Prospective Payment System or IPPS and Long-Term Care Hospital Prospective Payment System or LTCH PPS. CMS pays acute care hospitals with a few exceptions specified in the law for inpatient stays under the IPPS. Long-term care hospitals are paid under the LTCH PPS. Under these two payment systems, CMS sets base payment rates prospectively for inpatient stays based on the patient's diagnoses and any services performed. Subject to certain adjustments, the hospital receives a single payment for the case based on the payment classification assigned at discharge. The classification systems are for inpatient prospective payment system, it's called Medicare Severity Diagnosis Related Groups or Msdrgs, and for long-term care hospital prospective payment system, it's called Medicare Severity Long-Term Care Diagnosis Related Groups or MSLTC-DRGs. The law requires CMS to update payment rates for IPPS hospitals annually and to account for changes in the prices of goods and services used by these hospitals in treating Medicare patients as well as for other factors. This is known as the hospital market basket. The IPPS pays hospitals for services provided to Medicare beneficiaries using a national base payment rate adjusted for a number of factors that affect hospitals' costs, including the patient's condition and the cost of hospital labor in the hospital's geographic area. CMS updates long-term care hospitals' payment rates annually according to a separate market basket based on LTCH-specific goods and services. Proposed changes to payment rates under IPPS. The proposed increase in operating payment rates for general acute care hospitals paid under the IPPS that successfully participate in the Hospital Inpatient Quality Reporting or IQR program and are meaningful electronic health record or EHR users is projected to be 3.2%. This reflects the fiscal year 2023 projected hospital market basket update of 3.1%, reduced by a projected 0.4 percentage point productivity adjustment and increased by a 0.5 percentage point adjustment required by statute. Hospitals may be subject to other payment adjustments under the IPPS, including payment reductions for access readmissions under the Hospital Readmissions Reduction Program, payment deduction of 1% for the worst performing quartile under the Hospital Acquired Condition Reduction Program, upward and downward adjustments under the Hospital Value-Based Purchasing Program. The proposed increase in operating and capital IPPS payment rates, partially offset by decreases in outlier payments for extraordinarily costly cases, will generally increase hospital payments in fiscal year 2023 by $1.6 billion. In addition, CMS projects Medicare Disproportionate Share Hospital or DSH payments and Medicare Uncompensated Care payments combined will decrease in fiscal year 2023 by approximately $0.8 billion. Subject to determinations on applications for additional payments for inpatient cases involving new medical technologies following review of public comments on the proposed rule, CMS also estimates that these payments will decrease by $0.8 billion in fiscal year 2023. Under the current law, additional payments for Medicare-dependent hospitals and the temporary changes in payments for low-volume hospitals are set to expire in fiscal year 2023. In the past, these payments have been extended by legislation, but if they were to expire, CMS estimates that payments to these hospitals would decrease by $0.6 billion. Proposed changes related to Msdrgs. CMS is not proposing any new Msdrgs for fiscal year 2023, which means the number of Msdrgs would be maintained at 767 for fiscal year 2023. CMS is discussing a request to reclassify laser interstitial thermal therapy or LITT procedures under the Msdrgs in connection with a proposal to create new procedure codes to describe LITT. CMS is proposing to further delay implementation of the three-way split criteria because of the magnitude of the impact during the ongoing public health emergency. CMS is continuing their review of diagnosis codes along with a comprehensive review of the procedure code list, including when a procedure should affect Msdrg assignment. CMS also has a number of proposals for technical refinements to Msdrg assignments and is requesting comments on issues relating to the classification of rare diseases or conditions that are represented by low volumes in their claims data within the Msdrg structure. Social determinants of health comment solicitation. CMS is soliciting public comments on how the reporting of social determinants of health or SDOH diagnosis codes may improve their ability to recognize severity of illness, complexity of service, and or utilization of resources under the Msdrgs. CMS is also interested in receiving feedback on how they might otherwise foster the documentation and reporting of the diagnosis codes describing social and economic circumstances to more accurately reflect each healthcare encounter and improve the reliability and validity of the coded data, including in support of efforts to advance health equity. Payment adjustment for domestically made surgical N95 respirators comment solicitation. In a future pandemic or increase in community spread of COVID-19, hospitals need to be able to count on domestic manufacturers of surgical N95 respirators to deliver the equipment they need on a timely basis in order to protect healthcare workers and their patients. Sustaining a level of wholly domestic production of National Institute for Occupational Safety and Health or NIOSH approved surgical N95 respirators would help to maintain that assurance. CMS recognizes that hospitals may incur additional costs when purchasing wholly domestically produced NIOSH-approved surgical N95 respirators and is seeking comment on the appropriateness of payment adjustments under the IPPS and Outpatient Prospective Payment System or OPPS that would account for any such additional cost. CMS is considering such payment adjustments to apply to 2023 and potentially subsequent years. This rule outlines two possible frameworks to do so and seeks comment on these or other frameworks. Graduate Medical Education or GME proposals. First, CMS is proposing a modified policy to be applied prospectively for all teaching hospitals as well as retrospectively for certain providers and cost years. The proposed modified policy would address situations for applying the FTE cap when a hospital's weighted FTE count is greater than its FTE cap, but would not reduce the weighting factor of residents that are beyond their initial residency period to an amount less than 0.5. Specifically, effective for cost reporting periods beginning on or after October 1st, 2022, CMS is proposing that if the hospital's unweighted number of FTE residents exceeds the FTE cap and the number of weighted FTE residents also exceeds that FTE cap, the respective primary care and obstetrics and gynecology weighted FTE counts and other weighted FTE counts are adjusted to make the total weighted FTE count equal the FTE cap. If the number of weighted FTE residents does not exceed that FTE cap, then the allowable weighted FTE count for direct GME payment is the actual weighted FTE count. Second, the law requires caps on the number of FTE residents that each teaching hospital may include in its IME and direct GME payment formulas. To provide flexibility to teaching hospitals that cross-train residents, CMS allows teaching hospitals to enter into Medicare GME affiliation agreements to share and redistribute those capped slots to accommodate the actual rotations of their residents. The law also includes a provision allowing additional capped slots for urban hospitals that establish rural training tracks with rural hospitals, now called Rural Training Programs or RTPs. CMS's current regulations do not allow GME affiliation agreements for RTPs. Stakeholders have requested that RTPs be afforded the same flexibility as other teaching hospitals to share their RTP cap slots via special RTP affiliation agreements. CMS is proposing to allow an urban and a rural hospital participating in the same RTP to enter into an RTP Medicare GME affiliation agreement effective for the academic year beginning July 1st, 2023. Uncompensated care payments. CMS distributes a prospectively determined amount of uncompensated care payments to Medicare disproportionate share hospitals or DSHs based on their relative share of uncompensated care nationally. As required under law, this amount is equal to an estimate of 75% of what otherwise would have been paid as Medicare DSH payments, adjusted for the change in the rate of uninsured individuals. In this proposed rule, CMS is proposing to distribute roughly $6.5 billion in uncompensated care payments for fiscal year 2023, which is a decrease of approximately $654 million from fiscal year 2022. This total uncompensated care payment amount reflects CMS Office of the Actuary's projections that incorporate the estimated impact of the COVID-19 pandemic. In response to concerns expressed by commenters that the use of only 1 year of data would lead to significant variations in year-to-year uncompensated care payments, for fiscal year 2023, CMS is proposing to use the 2 most recent years of audited data on uncompensated care costs from worksheet S10 of hospital fiscal year 2018 and fiscal year 2019 cost reports to distribute these funds. In addition, as CMS expects that fiscal year 2024 will be the first year that 3 years of audited data would be available at the time of rulemaking for fiscal year 2024 and subsequent fiscal years. CMS is proposing to use a 3-year average of the uncompensated care data from the 3 most recent fiscal years for which audited data are available. For example, for fiscal year 2024, CMS expects to use audited data on uncompensated care costs from fiscal year 2018, fiscal year 2019, and fiscal year 2020 cost reports to determine eligible hospitals' uncompensated care payments. Beginning in fiscal year 2023, CMS is proposing to discontinue the use of low-income insured days as a proxy for uncompensated care in determining the amount of uncompensated care payments for Indian Health Service or IHS and tribal hospitals and hospitals located in Puerto Rico. Because CMS recognizes that this proposal could result in a significant financial disruption for these hospitals, CMS is also proposing to establish a new supplemental payment for IHS/tribal hospitals and hospitals located in Puerto Rico beginning in fiscal year 2023. Treatment of Section 1115 demonstrations for purposes of disproportionate share hospital or DSH payments. CMS is proposing to revise the regulation governing the calculation of the Medicaid fraction of the Medicare DSH calculation. Under this proposal, CMS would revise their regulation to explicitly reflect their interpretation of the language regarded as eligible for Medicaid only includes patients who receive health insurance through a Section 1115 demonstration itself or purchase such insurance with the use of premium assistance provided by a Section 1115 demonstration. Under this proposal, only the days of those patients who receive hospital health insurance that provides essential health benefits and, if bought with premium assistance for which the premium assistance is equal to at least 90% of the cost of the health insurance would be included in the Medicaid fraction of the DSH calculation, provided the patient is not also entitled to Medicare Part A. Cap on wage index decreases. After further consideration of the comments CMS received during the fiscal year 2022 rulemaking recommending a permanent policy to prevent large year-to-year variations in wage index values as a means to reduce overall volatility for hospitals, CMS is proposing to apply a 5% cap on any decrease to a hospital's wage index from its wage index in the prior fiscal year, regardless of the circumstances causing the decline. That is, under this proposed policy, a hospital's wage index would not be less than 95% of its final wage index for the prior fiscal year. CMS is also proposing to apply the proposed wage index cap policy in a budget-neutral manner through a national adjustment to the standardized amount. Current state of hospital assessment on the impact of climate change and health equity. CMS is soliciting comment via request for information or RFI on how hospitals, nursing homes, hospices, home health agencies, and other providers can better prepare for the harmful impacts of climate change on beneficiaries and consumers, and how CMS can support them in doing so. CMS is seeking comment on what HHS and CMS can do to help hospitals more effectively A. Determine likely climate impacts on their patients so that they can develop plans to mitigate those impacts. B. Understand the threats that climate change presents to their operations and better prepare for continuous operations should there be climate-related emergencies. And C. Understand how to take action to reduce emissions and track their progress. Measure suppression or refinement policies in response to COVID-19 public health emergency in certain value-based purchasing programs. Since the COVID-19 public health emergency or PHE is ongoing, CMS is proposing to suppress or refine several measures in the Hospital Readmissions Reduction Program or HRRP, Hospital Acquired Condition or HAC Reduction Program, and Hospital Value-Based Purchasing or VBP program. These policies are intended to ensure that these programs do not reward or penalize hospitals based on circumstances caused by the public health emergency for COVID-19 that the measures were not designed to accommodate. Examples of the types of external factors that the public health emergency has had that may affect quality measurement include changes to clinical practices to accommodate safety protocols for medical personnel and patients, as well as unpredicted changes in the number of patient stays and facility level cases. Hospital Readmissions Reduction Program or HRRP, proposing to resume the hospital 30-day all-cause risk standardized readmission rate or RR following pneumonia hospitalization measure, which is also National Quality Forum measure number 0506, beginning with the fiscal year 2024 program year following suppression of this measure, which was previously finalized for fiscal year 2023. Modifying the hospital 30-day all-cause risk standardized readmission rate following pneumonia hospitalization measure, which is also National Quality Forum measure number 0506, to exclude COVID-19 diagnosed patients from the measure denominators, beginning with the fiscal year 2024 program year. Hospital-specific reports for this measure would include this modification for the fiscal year 2023 program year. However, because the measure has been suppressed for the fiscal year 2023 program year, these data will not be otherwise available. Modifying all 6 condition/procedure-specific readmissions measures to include a covariate adjustment for history of COVID-19 within 1 year preceding the index admission, beginning with the fiscal year 2024 program year. Seeking public comment on promoting health equity through possible future incorporation of hospital performance for socially at-risk populations into the Hospital Readmissions Reduction Program. Hospital Acquired Condition or HAC Reduction Program. In the fiscal year 2023, IPPS/LTCH-PPS proposed rule. CMS is proposing to suppress the CMS PSI 90 measure and the 5 CDC NHSN HAI measures from the calculation of measure scores and the total HAC score, thereby not penalizing any hospital under the HAC deduction program fiscal year 2023 program year. CMS is also proposing to publicly and confidentially, through hospital-specific report CDC, NHS, and HAI measure results but not calculate or report measure results for the CMS PSI 90 measure for the HAC deduction program fiscal year 2023 program year due to misaligned data periods. CMS is proposing to suppress calendar year 2021 CDC, NHSN, HAI measures data from the fiscal year 2024 HAC deduction program year, making a technical update the measure specification to the minimum volume threshold for the CMS PSI 90 measure beginning with the fiscal year 2023 program year, making a technical update the CMS PSI 90 measure specifications to risk adjust for COVID-19 diagnosis beginning with the fiscal year 2024 HAC deduction program year. CMS is also requesting information from stakeholders on the potential future adoption of two digital National Healthcare Safety Network or NHSN measures, the NHSN Healthcare Associated Clostridioides difficile infection outcome measure and NHSN hospital onset bacteremia and fungemia outcome measure. CMS is also requesting information on overarching principles for measuring healthcare quality disparities across CMS quality programs. CMS is proposing to update the NHS and CDC HAI data submission requirements for newly opened hospitals beginning in the fiscal year 2024 HAC deduction program year and clarifying the removal of the no mapped location policy beginning with the fiscal year 2023 program year. Hospital Value-Based Purchasing or VBP program. CMS is proposing to suppress the hospital consumer assessment of healthcare providers and systems or HCAPS and 5 hospital-acquired infection measures for the fiscal year 2023 program year. As a result of the above proposed measure suppressions for the fiscal year 2023 program year, less than half of the hospital VBP program measures would then be available for accurate national comparison. Therefore, CMS is also proposing to not calculate a TPS for any hospital and to instead award all hospitals a value-based payment amount for each discharge that is equal to the amount withheld. CMS is also proposing to calculate measure rates for all measures and to publicly report those rates where feasible and appropriately caveated. CMS is also proposing to update the baseline periods for certain measures for the fiscal year 2025 program year. The agency is also announcing that CMS is making technical administrative updates to the measures included in the clinical outcomes domain. Changes to payment rates under long-term care hospital prospective payment system. For fiscal year 2023, CMS expects LTCH PPS payments to increase by approximately $25 million. LTCH PPS payments for fiscal year 2023 for discharges paid, the standard LTCH payment rate are expected to increase by approximately 0.7% due primarily to the annual standard federal rate update, that is the productivity adjusted market basket increase for fiscal year 2023 of 2.7% and a projected decrease in high cost outlier payments. Extensions of the Rural Community Hospital and Frontier Community Health Integration Project or FCHIP demonstrations. Sections 128 and 129 of the Consolidated Appropriations Act of 2021 respectively authorize a 5-year extension for both the Rural Community Hospital demonstration and FCHIP demonstration. CMS is including its proposals for implementing these extensions in the fiscal year 2023 IBPS/LTCH PPS proposed rule. Proposed revision to conditions of participation for hospitals and critical access hospitals to report data elements for COVID-19, seasonal influenza, and future pandemics and epidemics as determined by the Secretary. CMS is proposing revisions to the hospital and critical access hospital infection prevention and control conditions of participation requirements that would require hospitals and critical access hospitals after the conclusion of the current COVID-19 public health emergency to continue COVID-19 and seasonal influenza reporting. The proposed revisions would apply upon conclusion of the COVID-19 public health emergency and continue until April 30, 2024 unless the Secretary establishes an earlier ending date. In addition, CMS is proposing to establish reporting requirements for future public health emergencies related to epidemics and pandemics by requiring hospitals and critical access hospitals to electronically report information on acute respiratory illness, including but not limited to seasonal influenza virus, influenza-like illness, and severe acute respiratory infection, SARS-CoV-2, COVID-19, and other viral and bacterial pathogens or infectious diseases of pandemic or epidemic potential only when the Secretary has declared a public health emergency directly related to such specific pathogens and infectious diseases. Specifically, when the Secretary has declared a public health emergency, CMS proposes to require hospitals and critical access hospitals to report specific data elements to the CDC's National Health Safety Network or NHSN or other CDC-supported surveillance systems as determined by the Secretary. The proposed requirements of this section would apply to local, state, and national public health emergencies as declared by the Secretary. These proposed requirements would also allow for reduced frequency of reporting and modified or limited data elements that might be required at the discretion of the Secretary. Hope you found this information useful. If you enjoyed this video, please consider subscribing to my channel. Thank you for joining me. Bye now.